Okay. Also, thank you for the invitation out here. It's my first visit to Portland, and I see why everyone tells me such good things about the place. So, it's my task to talk a little bit about a disease that we don't do so well at managing, and that's mantle cell lymphoma. So, in distinction to what we've heard already about Hodgkin lymphoma and CLL, where we do a good job of curing patients in the former case and managing patients in the latter, mantle cell lymphoma is an example of a diagnosis that a patient gets and effectively gets a recommendation that can span the gamut of treatment options, anywhere from no treatment at all to the most intensive therapies we offer to these types of patients. And so I want to drill down into some of the reasons for that and some of the ways forward, I think, as we learn more about this disease. And the other thing to say at the outset is that this is a new disease. So this has only been a distinct entity for about 20 years. So it was discovered effectively as its own entity in 1993. And so that partly plays into why we haven't been as knowledgeable as we are about other diseases such as Hodgkin. Okay, so I have nothing to disclose. And so then just to start with a quote, of course, when there is a new disease and then there are new changes and more understanding of the biology about what makes this lymphoma different than others, then we see changes. And we've seen a lot of changes in this particular disease, even in the last year. I think that bodes well for the future of how we're going to manage patients, irrespective of their age. Okay, so what I'll do, the way I've structured this talk, is I'll go into a little bit of the management approaches. I use that term approaches, and with the caveat that true personalized medicine, or an ability to understand what's the right treatment for the patient in front of you, still is not achievable, although it is a goal. We do have new FDA-approved therapies for mantle cell lymphoma, which is exciting, and I personally believe these will change the way we manage these patients in the not-so-distant future. And then I'll touch a little bit on some emerging concepts having to do with how we manage them and some new targets. So the questions that are in the mind of the patient and the investigator when you see a new patient is pretty basic. When do I start therapy? Do I have to start therapy immediately? And I think there is certainly physicians that will treat all their mantle cell patients immediately. But I'm not sure that's necessary. And then the question is, okay, when I do need to start treatment, what's the appropriate induction therapy? And I use the word appropriate instead of most effective. And then we get into when do I stop therapy? And I'll show you some of the data that raises that question. And it's fair to say, coming out, that we can't get these questions wrong because there's no consensus, which is nice. It doesn't mean everything is equally correct. It just means that there's no general consensus on how to manage these patients. Okay, so mantle cell lymphoma effectively combines the worst features of non-Hodgkin's lymphoma, right? So if you have an indolent lymphoma, then the good news is most of the time it doesn't behave terribly aggressively. The bad news is we can't cure it today. If you have an aggressive lymphoma, the good news is we can cure you often, but you have to start treatment right away. And mantle cell, in many ways, sort of combines the worst of both of those. And I think it's important to note that the median age of the patients, they're mostly male, but the median age is over 65, and that's an important piece of information as we think about our treatments. Historically, it's had the worst survival of B-cell lymphomas, but in part that's because we haven't had effective treatments and we haven't known much about the way to treat it. I think that the modern therapy probably is extending this out to the 5 and 7 year range, and you could probably draw many comparisons to the way the landscape is changing for this disease as you might with, say, multiple myeloma. Most of the time, the disease is advanced. So in a recent study that we've finished accruing at the NCI, we did colonoscopies on every patient, and every single patient had stage 4 disease. So effectively, we don't have a staging system for mantle cell lymphoma. Most of the time, it's advanced stages. Even if there's limited tumor burden, the Ann Arbor staging system isn't effective. And frequently, the sites that are involved are extranodal. And so this all leads to this problem we have therapeutically, in that there's considerable disease heterogeneity from the outset, and we don't have many randomized trials as a bedrock of information on how to proceed, and that limits some of our understanding. Okay, so this is a paper that confirmed what many people felt was the case for a long time. And this is a retrospective series from Cornell. And basically what this is they looked backwards at their records of hundreds of patients, and they found about 100 patients that they didn't they didn't give therapy, or they addressed when they started their first therapy. So these are 97 patients that they didn't immediately start therapy. And you can see here that the majority of them, within the first 3 months, the investigator decided they did need treatment. But down here are examples of patients that went many months afterwards if they had no therapy at all, and some patients out here even past 5 years with no therapy at all. And if you look at the overall survival from the time that they were actually diagnosed, on the blue here is the observation group, which sort of confirms to me that two things. One is that not all patients that are just diagnosed need treatment, and the other thing is your treatment you give could put a patient on this yellow line if you're not careful, if you choose the wrong one. So then what does predict outcome? If we don't have a staging system, then what is it that predicts outcome? And this is a study from the NCI that did gene expression profiling, looking effectively at proliferation signature of 20 genes, as you see here, and breaking down patients into separate quartiles. You can use the score they get on that signature to predict who will do worse and better, the quartile 1 being low proliferative tumors and quartile 4 being highly proliferative tumors with less than a year survival in that time frame. But that's a gene expression profile. That's not something that we can get in the clinic. We can't order that. We can't send that off and get that result. So how do we capture that in our clinic? Well, Ki67 is a marker of proliferation of tumors. We know that. And this is something that across multiple studies has been shown to be prognostic. This is an example of that. This is a histologic example of a highly proliferative tumor, or I should say a high Ki67 score versus a low. And that does also translate into different groups of survival. The problem here is that this is something that is difficult to, there's significant inter-observer variability here, and so one pathologist may see something different, their eyes may be trained to see something different and score this differently. And so if you take a look at the scores, 5 to 20 is low, 20 to 40 is intermediate, and so on and so forth. So it's difficult to use this as a clinical tool as of now. So another thing that we apply to many different lymphomas is a clinical prognostic score, or features that might be present in them based on the patient as well as the way they present, and try to predict how they will do. So we're all familiar probably with the International Prognostic Index. That's been applied to specific subtypes of lymphoma, the FLIPI, and in this case, this was a large series that tried to apply similar data to mantle cell and named the MIPI. So this is 3 different trials with all advanced stage patients, which I told you everybody is. And effectively, this is a clinical score that adds up the age of the patient at diagnosis, their performance status, the LDH as it relates to the reference lab, and then the presenting white blood cell count. And then the original study, as represented here, this was actually algorithmic, and it was put in, and there was logarithmic scores. And then if you were low risk, you had a much better prognosis than if you were intermediate or high risk. So it did do its job of predicting who would do better and who would do worse. Although this is, again, not a tool to help predict or identify who should get treatment. It simply is a way for us to compare different clinical trials across treatment arms. So one of the problems with not having a biologic marker of who's going to do poor or not is patient's age is not a good predictor of who's going to do well. And white blood cell count, it turns out, has many confounding variables as well. So what we'd really want is something that's more biologically based. And this is something that's been an investigation for a while. There has been an observation across the world that patients that have the indolent form of mantle cell lymphoma, if we can use that term, frequently will present without lymph nodes. So oftentimes these are patients that do have an elevated white blood cell count, and perhaps they even have splenomegaly. And other times we will observe that frequently these patients will get diagnosed with CLL because their phenotype, their clinical phenotype looks very much like CLL. So these investigators wanted to drill down into that a little bit further and try to understand if there was a predictive biomarker available. So what they did was they did gene expression profiling on patients, about 12 patients that they knew, because it was retrospective, did very well without any treatment. And they compared the gene expression profile to those that did much worse or had a more aggressive course. And the gene that seemed to stand out was something called SOX11, which is a transcription factor that seems to code for angiogenesis or other things that are less well described. So then they asked the question, well, again, gene expression profiling is not available to us in the clinic, so can we predict this with immunohistochemistry? And they asked that question. They validated their findings effectively with a larger group of patients. Here's about 115 patients, and they noted that the lack of SOX11 expression is noted up here. SOX11 negative cases, these are 15, compared to SOX11 positive cases, which is the majority of cases, 97 had a much worse prognosis. Other features that were seen in the patients that had an indolent form of mantle cell lymphoma, I had mentioned non-nodal presentations, a hypermutated variable region of the immunoglobulin receptor, which is akin to what we see in CLL again, and much less complex karyotype or fewer genomic imbalances. So we asked this question in a recent study that we did at the NCI if this could be predicted with something that's more readily available, i.e. a PET scan. So over the last 5 to 10 years, effectively all patients with non-Hodgkin's lymphoma have a PET scan, and so it's a readily available tool. And we asked the question is, do the findings on the PET scan actually correlate to tumor proliferation as measured by this gene expression profiling, which has already been validated as a marker of prognosis in mantle cell? Well, there are difficulties in interpreting a PET scan. We all know that, but there's many, and it's related to not only features of the tumor, but also features of the tumor size, the PET scanner, and different biochemical enzymes that are within the tumor. Effectively, the idea behind a PET scan is that the FDG-marked glucose will be taken up more by the malignant cells, and also will be trapped because they'll lack the GLUT transporters to get rid of the FDG. But that doesn't always apply, and when we use this, we don't really get a quantitative number, but we get a semi-quantitative number. And so there are some advantages and disadvantages to using a PET scan to try to understand the tumor proliferation of the patient. And effectively, we're getting at whether or not the patient can safely be watched. So the advantage is it's readily available. Everyone effectively gets this. It does give you a number that you can use, the SUV. It's easy to understand, and you can apply that. And you don't have to do a biopsy to get the Ki67 or get the gene expression profile signature and the like. The problem is there's multiple confounders, and there was really never any understanding if this was specific for proliferation or does it measure many other things that are important for tumor progression that have nothing to do with proliferation. So we directly asked that question. This is the early data that we presented a few years ago. And effectively what you see here is PS refers to the proliferation score on gene expression profile, SUV of the lymph node that was biopsied in comparison. And you see a correlation that is moderate to strong here, R coefficient of 0.45. So it does correlate to proliferation. In fact, all of these things correlate to proliferation. The MIB score is the antibody against Ki67, so that's the same thing as a Ki67 score. The serum LDH also correlates to the SUV, and then they also correlate to each other. But I will note that the correlation is not as strong as you might expect for something that was very specific for tumor proliferation. And so currently we're investigating some of the other genes that seem to be correlated with the SUV and seem to explain some of that SUV. And the take home from that is that effectively is wrapped up here in a clinical table. So if we look at the SUV and we want to use that as a marker for who we can safely omit therapy, it probably isn't very effective. In other words, the high-risk patients by MIPI had the same, in fact, they even had lower SUV maxes than the low risk. And except in the 5 patients that had a truly different morphology under the microscope, the blastoid morphology, was the SUV any different? Effectively, it was the same in almost all the patients. And this finding also held true as it related to the proliferation score. I didn't show you that data here. So to summarize that portion, effectively, we don't have standard approaches to the patients, and we don't yet have predictive markers that tell us who is highly proliferative and who isn't. And so it's left to many other factors that help make the decision on how we treat our patients. So most of the time when people hear mantle cell lymphoma, they think of highly intensive therapy. And they think highly intensive therapy that includes potentially autologous stem cell transplant, presumably high-dose ARC. And I just want to show you that data, where that comes from, and leave it to your own devices if that's what you believe is the right thing to do in all your patients. This is an example of something called the Nordic lymphoma group. This is their data here in progression-free survival in their MCL2. And what this is effectively MCL2 was a subsequent study from MCL1 where they added in both rituximab as a way to purge the stem cells prior to transplant, and they also added in high-dose cytarabine. And what you do see is a very impressive 7-year progression-free survival of 66%. So clearly this is something that is highly effective, and many patients go a very long time before they progress. The problem with this is, of course, adding in auto-transplant in a non-curative setting introduces a lot of toxicity. And if you go back to the original slide from Cornell, some of these patients go over 5 years with no therapy at all. And so it raises the question of how we select the patients for this type of therapy. The other regimen that is quoted frequently as having very, very high response rates with similar troubles is the regimen from MD Anderson, Hyper-CVAD, which was a regimen that was first developed as a treatment of ALL. And it can be applied to mantle cell lymphoma, particularly if the patient is younger, and it can be highly effective. This is 10-year follow-up that shows very, very high complete remission rates and a similar progression-free survival, or in this case, time to next treatment, or time to treatment failure of about 6 years. What was originally hoped was that this would result in a plateau, or that we would be seeing that we were curing patients with this type of highly intensive therapy, but that has yet to be proven, and it looks by the curves that this is probably not the case. Or if it is the case, it's probably a select number of patients that are under the age of 60, and so not applicable to most of our patients with mantle cell. This slide is designed just to highlight the fact that R-CHOP therapy by itself, which is sort of like if you don't know what to use in non-Hodgkin's lymphoma, just pick R-CHOP, you're okay. Well, I would submit to you that's probably not true in mantle cell lymphoma. So this is an example of data that shows you that yes, rituximab does improve the response rates, but if you look here, compared to 6 years with highly intensive therapy, R-CHOP is less than 2 years, and with a wide variation. So R-CHOP by itself, with no follow-on therapy, is highly ineffective in most cases for mantle cell lymphoma. So what else could you use? Well, this is a subset analysis of a study from Germany that was powered as a non-inferiority trial, and effectively what they were trying to do was demonstrate that bendamustine rituximab was at least close to as good as R-CHOP with less toxicity. And they found a surprising result that not only did it have less toxicity, at least in their study, but it also was more effective across the whole group. This is an example of the subset analysis of mantle cell lymphoma itself. So in the whole group, the CR rate was about 40%. In this group of mantle cell that was subsetted out, the progression-free survival if you give bendamustine was 69 months compared to 31 months with R-CHOP. So that study got a lot of people interested in using bendamustine, particularly in those that they weren't enthusiastic about doing autologous stem cell transplant, or they didn't want to give Hyper-CVAD to, and the question then became, can we find this in other studies? So this is an example of an American study that tried to find similar results with bendamustine rituximab compared to R-CHOP, and half the patients actually in the control arm got RCVP. But their endpoint was different. Instead of progression-free survival, they were interested in determining the response rates. So that is, again, here, this wasn't a trial specific for mantle cell lymphoma, but the subset here in mantle cell lymphoma did show, with a pretty wide confidence interval, did show what appears to be favorable response rates to bendamustine rituximab over R-CHOP. But you can see the CR rate is about 30%. So the way I would interpret these data is that bendamustine probably is much more active in mantle cell lymphoma than R-CHOP. In many situations, it has less toxicity. But if you just want to look at the CR rates and PFS, it's not nearly as effective as the highly intensive regimens. And so that's the decision that we're faced with in many patients. Okay, so again, most of the patients with mantle cell lymphoma are going to be in the group of patients over the age of 65. And so many times we don't need to have that very critical discussion of whether or not they want intensive therapy. But after you give the first induction and achieve a complete response, are you done at that point? So that gets to my third question of when are we to stop our treatments? So this is a study that was done from the European MCL network, and it was a double randomized study. And by that I mean there was 2 randomizations between the induction, where the patients were randomized to either receiving R-CHOP or R-fludarabine cytoxan, and the second randomization in those that had a response into maintenance with either interferon or rituximab. And all of the patients here were deemed ineligible for transplant because the standard of care in Europe still remains to give all younger patients or patients that can tolerate an autologous stem cell transplant. So these patients were determined at eligibility to not be transplant candidates. The other important caveat to this study that I want to point out is that the maintenance rituximab was indefinite. So across different lymphoma trials, you'll see different schedules. It gets confusing at times. And in this case, the idea was to give it every 2 months, as we see many times now, but to continue it indefinitely until progression. Didn't stop at 2 years. So what was found is that if you look at the whole group, there was definitely advantage as far as remission duration in giving maintenance rituximab compared to interferon, so no surprise. That did not result in an overall survival advantage. What did result in an overall survival advantage, however, is in the patients that got R-CHOP during induction. If they got rituximab maintenance again indefinitely, they did have a statistically significant improvement in their overall survival and a reasonable 4-year overall survival of 87% in this population. That's the best data we had seen to this point, and arguably became the standard of care as it was published in this group that are ineligible for stem cell transplant. So those are the data that I would categorize as platforms or chemotherapy platforms that you might choose from, but it doesn't incorporate some of the novel agents. So we've had Velcade available or bortezomib available for almost 10 years now in mantle cell lymphomas, approved in 2006. And the idea is, as you add that, can you remove something else and improve upon those results and maybe potentially get around the idea of needing transplant? So this is an example of a regimen that is Velcade based. So this regimen was basically developed in the Wisconsin Lymphoma Network and then taken to this study, which is an ECOG study, a multi-center study, and effectively think of it as the hyperfractionated cyclophosphamide, which is seen in hyper-CVAD. It does not have the high-dose methotrexate, which is difficult to tolerate, and instead of vincristine, they gave bortezomib. They also asked a question in a non-randomized way of whether or not maintenance rituximab could get as good a results as you could see with autologous stem cell transplant. It was non-randomized. It was determined by the patient and the treating physician. But what they effectively found was very good response rate, CR rate of 68%, very good 3-year progression-free survival, better than we might expect. Again, it's not a randomized trial, but better than we might expect from what we've seen with bendamustine and R-CHOP. And that there was no advantage, again, in a non-randomized way, to giving an autologous stem cell transplant over just giving maintenance rituximab in this group. So that led to the idea that perhaps these novel agents that work in a new way might actually improve our ability to treat these patients and get rid of this difficulty of needing to discuss patients' very intensive therapy. So this is a study that was just presented at ASCO. And effectively what this is a multi-center study, international study. And this is basically asking the question in patients that are ineligible for transplant, again, if you substitute bortezomib for vincristine, can you improve upon the response rates and the progression-free survival? And the answer is yes. So this is a randomized study again, and what they found by the independent review committee was that the progression-free survival when you gave Velcade, again, instead of vincristine, was statistically significantly better, 24 months compared to 14, and a 59% improvement in progression-free survival. The other piece of information here is that R-CHOP, even when it gets complete remissions, frequently are very short-lived. So the other question that's important in incurable illnesses is those patients that do get a remission, how long does it last? So that is reflected here, is that the other exciting thing about this is that there's a hint in this that perhaps this is changing the natural history of the disease by giving bortezomib. What I mean by that is in the patients that did get deep responses, R-CHOP again was what you might expect, less than 2 years, but the patients that got deep remissions with Velcade-based treatment, it was lasted over 3.5 years. So those data have led to a multi-center study also led by the ECOG that's asking multiple questions. This is a randomized phase 2, sort of a pick the winner design, but it's important to know about the study. It would be an example of a study we could refer our patients to. We don't have this at our institution, but I wanted to bring it forth. And they're asking multiple questions here, but they're focusing on the most appropriate induction regimen, effectively bendamustine or bendamustine plus Velcade, which I didn't show you but does have acceptable toxicity as demonstrated in a phase 2 study. And then the second question then is effectively saying maintenance probably is good in this disease. Can we give more intensive maintenance with the addition of lenalidomide? And which one of these shows us the best response rate? So my summary of induction therapy is, first of all, recognizing that not all patients need immediate therapy. We don't have a predictive biomarker to tell us who does and who doesn't, which makes for a very difficult discussion in some patients. Intensive regimens, it is fair to say, definitely are the most effective at inducing a CR and the longest progression-free survival, but they're highly toxic and they do not appear to cure patients. It looks like Velcade and perhaps bendamustine are more effective platforms. They have more toxicity by which we could build upon and add agents to, and that's exciting as a researcher. And probably if you do decide to give R-CHOP to your patients, you probably should strongly consider giving maintenance rituximab given the fact that it improves overall survival in a randomized fashion. So the last thing to talk about then is if we're really making a dent in this disease, if we're really going to change the landscape, then what are the players that are going to do that, or how are we going to do that? So it takes a long time, of course, for drugs to be developed, and that's a major hurdle. So when patients don't participate in clinical trials, or we don't refer patients to clinical trials, this goes longer. And what's exciting, however, in mantle cell lymphoma is that we had a new drug in 2006, which looks to be effective, but as most people know, does have some troubling side effects with neuropathy and the like. But within the last year, or just over a year, there's been 2 new drugs that are oral, both approved now for relapsed refractory mantle cell lymphoma. These data are what led to the bortezomib approval. You can see here that at the time, this was very exciting data. Most patients were negative on the waterfall plot, but the CR rate was pretty modest, only 8% as a single agent in relapsed patients. However, if we look at lenalidomide, which we've seen works in other lymphomas, of course, and multiple myeloma, and not only do we see that the response rates goes up into the 30% range, but the duration of remission as a single agent, oral medicine that the patient could effectively stay on for long periods of time was longer, into the 16 to 18 month range. And recently, a group that first studied lenalidomide in a bunch of different lymphomas reported their long-term data. So these are the kind of data that get really exciting because when we see the response rates that get published, we don't know what that ultimately translates to. However, when we see these long-term follow-ups, what we see here is that all these patients had relapsed refractory mantle cell lymphoma, which, if we go back to the textbook, is going to tell us has a median survival of about 3 to 5 years at the time of diagnosis. And what we're seeing here is that with this single agent alone, you can see there seems to be a flattening of the curve when you get right to here, maybe as high as 35 or 40% of patients that are going all the way out now to almost 3 or almost 4 years on the treatment without progression. And that's really exciting. Even more exciting, in my opinion, is the fact that we're becoming more bold and we're saying, okay, if it's that effective, then do we need chemotherapy? Let's not talk about high-dose cytarabine. Let's say, do we need chemotherapy at all, or can we get remissions in patients even with these as the platform itself? So these data were presented at ASH this last year. It's a very small number of patients. It was the first look at this data, and they, again, excluded patients that were under the age of 65, i.e. the transplant-eligible group. And they gave it on a relatively standard schedule, and then gave it as sort of a maintenance strategy after that. Rituximab was given 4 times, and then every other cycle for a total of 9. And they saw an overall response rate of 87%, with a very respectable CR rate of 57%. So again, these are very early data, but something that has led to a lot of enthusiasm as a sign that perhaps we are moving to an era to where at least some patients can be treated without chemotherapy. Okay, so you couldn't talk about mantle cell lymphoma or pretty much any lymphoma these days without talking about ibrutinib. So we've heard about the way that this was developed and some of its specificity. So how does it work in mantle cell lymphoma? Well, the biologic basis behind this was not worked out in the same way it was in CLL or even large cell lymphoma for that matter, and that it was somewhat serendipitous to find that that there were mantle cell patients that seemed to be addicted to chronic B-cell receptor signaling. That was a surprise. But from that, this study was published where 111 patients were given this as a single agent. All of these patients had relapsed refractory mantle cell lymphoma, and about half of them were bortezomib resistant. And the overall response rate was 68, this should be percent, with a CR rate of 21%. And the median duration of response was about 18 months. Very, very respectable. And it did not seem to matter whether or not the patients had bortezomib prior. And so this is what effectively led to the registration of, or this was the registration trial that led to the approval of ibrutinib for relapsed refractory mantle cell. So the way I summarize what we know right now about novel therapies is that we now have 2 new novel agents, and the goal of research is to then understand who are the right patients that should get one versus the other versus the combination and the like. So there are combination trials ongoing in the upfront setting. As I showed you one with lenalidomide, there's also a randomized trial of bendamustine, rituximab, placebo versus ibrutinib that's available. It's a multi-center study that what we should consider referring our patients to as well. But I still think that the goal of this precision medicine where we can sort out in the clinic which is the patient that should get this agent or this treatment or that treatment is still outside of our reach. We don't have the tools. The tools are emerging and they're getting better, but we still don't have predictive biomarkers that tell us who needs to be treated at all when we first get diagnosed. And therefore, the clinical trial participation that we all refer patients to really is a must for us to understand some of these biomarkers, some of the translational science that is very important in advancing our understanding of this disease. So I'd like to acknowledge my colleagues that helped with some of the data we generated here on the PET scan and our clinical team, and then leave this slide in case you have any questions now or later to contact us.